Next, I would like to invite Dr. Rekha Rajesh. Yes, ma'am.
Good morning, everybody. And at the outset, I'd like to thank the organizers of COGS for giving me this opportunity. Today is heavy menstrual bleeding in infertility. And I think this is covering the whole textbook. And Anit and the team have given me a big job actually. Abnormal bleeding or heavy menstrual bleeding by itself does not cause infertility. However, its presence can signal an underlying problem that may be affecting a woman's fertility. This heavy menstruation may also indicate any pathology or malignancy, and the discomfort caused affects her quality of life. Menorrhagia is defined as unusually heavy or prolonged bleeding. The average menstrual blood loss is around 30 to 45 ml over 4 to 5 days. But these patients experience bleeding more than 80 ml, which lasts longer than 7 days. This heavy bleeding can cause soaking of more than one pad or tampon for every hour or several hours in a row. There are different causes, and these causes are categorized in three headings, where we have uterine problems, hormone-related problems, and other illnesses. The uterine problems could be fibroids, polyps, irregular ovulation, adenomyosis, endometriosis, non-hormonal IUDs, PID, malignancy, inherited bleeding disorders, and medication. The others could be thyroid disorders, prolactinomas, liver or kidney diseases. The associated symptoms could be anemia, fatigue, shortness of breath, constant lower abdominal and pelvic pain, and the inability to perform regular daily activities because of the excessive bleeding. Now, according to the FIGO classification, we will classify based on this mnemonic palm coin, and the causes are similar in all these women. But how they cause infertility is what we are going to decipher today. The classification here is heavy menstrual bleeding or intermenstrual bleeding based on the palm coin. And the first thing that we would see is a polyp. The polyp could be intrauterine, cervical, or it could be a small polyp or a big one. It is usually detected by ultrasound or sonohysterography, and sometimes it causes very heavy bleeding. And the cause for infertility could be obstruction and improper implantation. And the treatment usually is after a hysteroscopy or a saline sonography, you have to do a hysteroscopic polypectomy. Now, adenomyosis is one of the controversial causes for bleeding in infertility. It is diagnosed based on the ultrasound or the MRI, and this is usually causing impaired implantation in the women, and then short of preterm birth and placental abnormalities because of the location of the placenta, IUGR or preterm birth. Now, fibroids is one of the again mechanical obstructions caused, and this could be because of the location. It may be a submucous fibroid or an intramural fibroid. Based on the location and the classification, we treat these fibroids. Anything less than 3 centimeters, and if it is a subserous fibroid, we are not worried. The ones that we are worried about are the submucous and the intramural fibroid, which affect the endometrial contour or affect the implantation. For these patients, we would do a myomectomy. And malignancies in some patients are also seen, where if it is an ovarian cause, we usually ask them to freeze their oocytes, and if it's an endometrial cause, we need to treat them accordingly. Anovulatory causes of AUB could be because of anovulation, it could be physiological, and in PCOS, stress, obesity, weight changes, exercise, endocrine, thyroid or prolactin or hormone secreting tumors. The non-structural causes again are because of the coagulopathies or bleeding disorders, ovulatory dysfunctions, endometrial, iatrogenic causes, and some yet to be classified. Endometriosis is again one of the commonest pathologies we see in infertile patients, and this is causing dysmotility in the tubes, sometimes poor oocyte quality, and implantation failures. Usually the pregnancy outcomes are better in these patients compared to the adenomyotic patients. And the symptoms of endometriosis include very painful menstrual cramps, lower back pain, pain during sex, painful bowel movements and urination, bleeding or spotting between periods, digestive symptoms, and infertility. Most of these patients need to be diagnosed properly, and history forms the basis of these diagnoses. We have to decide whether it is acute or chronic, characterize the bleeding pattern, take the menstrual history of the patient, for the duration. Here what we usually say is, we take the rule of 7, where for 7 days before, 7 days after, and 7 pads per day is close to normal. Anything beyond this is supposed to be defined as an excessive bleeding pattern. And we also have to rule out a family history of abnormal bleeding patterns or bleeding disorders, and also medications that they are on, probably warfarin, heparin, NSAIDs, OCPs, and other supplements that they take. Physical characteristics is something that we have. Once we see the patient, if she is a PCO, she would be obese, there should be hirsutism or acne. In a thyroid dysfunction patient, we could see that either she would be obese or thin, she could be having heat intolerance, dry skin, lethargy. And in diabetic patients, we would usually see acanthosis. In bleeding disorders, we see petechiae, pallor, signs of hypovolemia. And pelvic examination is the important thing that we should not miss in any patient. So a clinical examination is very important, and we should rule out if the bleeding is from the uterus. And investigations, definitely when this patient comes and we see, we should rule out pregnancy, do a basic blood screening test, and targeted bleeding disorder tests and thyroids and prolactin. In case of infection or high-risk patients, you can rule out gonorrhea or chlamydia. Imagings that we use usually are the ultrasound, sonography, hysteroscopy, MRI, endometrial biopsy and pap smear in these patients are also recommended. Saline sonography, see, a 2D ultrasound is the basis of any diagnosis in these patients. A good 2D and 3D ultrasound will be able to diagnose whether it is the location of the fibroid, the adenomyosis, the endometriosis, and to what extent it is affecting our endometrium, and how are we going to plan the infertility treatment for this patient. And then in hysteroscopy, what we see is the location of the polyp. This can be both diagnostic and therapeutic. And hysteroscopy, we can do a hysteroscopic removal of the myoma or the polyp based on its location. Saline sonography, we usually do it to identify the location of the polyp and see, and also for guiding us how to plan the polypectomy. MRI is mostly used in patients where we are diagnosing for either adenomyosis or endometriosis, to see the location, to identify the extent, to stage the disease, and then based on the impact of the staging, we are going to plan the treatment for these patients. Most of these patients are all conservatively managed. The first line of therapy would be to treat anemia, use OCPs to regularize the cycles and stop bleeding completely. Tranexamic acid is the first line of choice, and we could give them cyclical so that during that bleeding time, it helps to reduce the blood loss. The treatment is either for acute or chronic. Based on the presenting symptoms, we decide how much of the OCPs that we are going to do, or are we going to do a therapeutic curettage or give them any IV estrogen. In other stable patients, we would usually start with OCPs, use medroxyprogesterone acetate and tranexamic acid either singly or in combination during these cycles. The non-surgical treatments that we do is first expectant management, NSAIDs, antifibrinolytic agents, that is tranexamic acid, and hormonal methods in combination. And sometimes we do use, in a very big adenomyotic uterus, we would prefer to use a levonorgestrel IUD so that it helps to shrink the uterine size, improve the uterine contour, and probably give us a better outcome in these patients when we do an embryo transfer. And usually we use cyclical progesterones, and GnRH agonists are used in both endometriosis and adenomyosis and in fibroid patients. In patients with PCOS who are obese, these people will benefit by adding metformin and other insulin sensitizing agents to regularize the bleeding in PCOS women. The surgical interventions usually would be only a therapeutic curettage, sometimes uterine artery embolization, but if we are planning, again, the implantation results are affected by this. Operative hysteroscopy is the gold standard, and ultrasound ablation for some patients, myomectomy in cases where they require myomectomy, very rarely endometrial ablation unless we are having no other choices. The other disorders that we are going to treat them is the hypothyroid and the hyperprolactinemias, so that the cycles are regularized and the bleeding is controlled. PID is treated with antibiotics. If they have any liver or kidney diseases, accordingly they are being analyzed and treated, and malignancies have to be evaluated and planned. And if they have, only if they don't have a uterine malignancy, we will be able to help them conceive. In case of uterine malignancies, and depending on the stage, probably they may have to plan other methods. Thank you.